Okay, I'm going to talk about presentations for clinical rotations for third year and the SOAP format. My wonderful big gave me a rundown before my first rotation, so I felt like I kind of at least knew what to do. So I'm going to talk about that in this video so that anybody can watch it and have a little bit of a rundown before they start rotations. So you can see it's all about the SOAP format. The only thing that's more important than the SOAP format is maybe the one-liner, which is the thing that you say before the SOAP. SOAP is, subjective and objective, S&O, and then there's the assessment and plan. And it splits very nicely into two halves, the yin and yang of this SOAP, which is the SO versus the the AP, right? The first half versus the second. What I hear from attending to stuff on rotation is that basically this first half is the history. It's just you reporting information, as opposed to this second half is the actual clinical decision making. This is the part where you're actually contributing something. So it's this is the med student part. This is the doctor part. Of course, you as a med student, you're trying to imitate a doctor, so you need to do the whole thing. But my point is that they're kind of more impressed by this part, right? This last part, the assessment and plan. It's easier than you think to give us a history, subjective and objective, and then even forget to really say an assessment. There's one guy, Dr. Nelson, on OB-GYN. He said it's a SOAP note, not a SOP note, because people go S, O, and P and leave out the assessment. So I told you the last half is the most important. Out of these two, which is the most important? It's the assessment. As a student, this is the part that's going to look the most impressive when you actually say it, because it's easy to skip over. It's easy to say, well, the residents already told me what is going on and they already told me what the plan is, so I'm just going to copy what the resident said as my plan. Oh yeah, I give amoxicillin and fluids because that's what the resident told me, which is good. It's good to run by your plan with the resident, but giving an assessment lets the attending feel like you're thinking about what's going on. So anyways, long story short, assessment, it's your assessment of the situation. It's kind of like the diagnosis. It's where you would say your differential, top 3 most likely things you think it is. Or this is where you would say, if you already know the diagnosis, this is where you basically give a smiley face or a frowny face. In other words, you say this patient is well appearing. I think they're improving compared to when we saw them yesterday, if you're inpatient. Or you say this patient is ill appearing, or I think their anemia or their infection or their white count or their whatever is worsening compared to yesterday. So now that I kind of given the overall vibe of, the priorities here, focus on this even more than these. Now I can say the actual content of this stuff. So the most important thing is the one-liner. We'll start out with that. You say, Mr. Naruto is... Actually, I don't want to use Naruto because I'm going to give him a bunch of diseases. Mr. Well, you know what? I have to respect my patients, right? So I should use somebody I respect. Mr. Naruto is a 25-year-old... Now, let's make it actually realistic. 65-year-old male with past medical history of the stuff that everybody has. Hypertension, diabetes, right? Type 2 diabetes, because he's old. Hyperlipidemia, and tobacco use. Presenting with, or presenting for, chest pain, right? Because he's vascular, bad blood vessels, and smoking and stuff. So anyways, that was just an example. The whole point is that the one-liner is two things. It's the past and the present. Okay. That's the whole point of the one-liner. You just say who they are, right? Obviously demographic, their name, age, and sex. Then you say their past history, and then you say what they're here for now. Past versus present. That is your one-liner. Mr. Naruto is a 65-year-old male with a past medical history of hypertension, type 2 diabetes, hyperlipidemia, and tobacco use, presenting today for chest pain. Or who presented 3 days ago for chest pain. Yeah, let's get into more details. They like you to like say like timing. They're very obsessed with timing. Let me actually like put like pearls now. The parts that actually took me a long time to understand. If you can like remember this stuff earlier, it'll make you look like better. Like, oh, this student like really gets it. It took me a long time to get this. They really like time in medicine. That means if you're inpatient, especially, even an outpatient, it's about trending. When you tell them a lab, they don't want you to say, oh, the patient has a potassium of 3.4. They want you to say, this patient has a potassium of 3.4 compared to yesterday potassium of 3.0. So it's always about trending. It's always about trending. You don't want to tell them what the lab is. You want to tell them what it is relative to before, right? How is it changing? It's also like whenever you're on surgery or OB-GYN or something, if the patient had like any kind of surgery or procedure, they like you to say post-op day, right? This Mr. Naruto is a 65-year-old female with a past medical history of preeclampsia, who presented for a C-section, and see, I don't even remember how to say it. Miss Naruto is a 65-year-old. No, Miss Hinata is a she's C-section. Miss Hinata is a 28-year-old female with a past medical history of preeclampsia, post-op day 2 from a C-section. See, that's what they want you to say. So it's like in that one-liner, if they just had a surgery, you will say like what day they are out from their surgery. Timing. Again, they always like you to include timing. That's my point. Whether you're trending labs in the objective or presenting your patient in the one-liner. Timing is very important. And in your assessment as well, right? So in your objective history, you're trending. It's about timing. In your one-liner, it's about timing. In your assessment, it's about timing because you want to say, has this patient improved or not? Have they gotten better or worse? Right? So all parts of the history, timing is like a big thing. These pearls are the parts that will make you look like more impressive. This is not like the bare minimum part. This is the part that's like makes you like, stand out a little bit. Not that I stood out, but it's that I realized afterwards, because it took me a long time to get it, so that you can stand out if you actually do this from the start. Okay, good. Okay, we finished one-liner, okay? That's not part of SOAP. That's the thing that comes before SOAP. That's literally how you start your presentation. That's like the title of your presentation. Now that we've done that, I will tell you that this one-liner, you will repeat it again when you do your assessment, right? Because like I told you, it's yin and yang. The beginning is SO, the end is AP. So when you transition from beginning to end, you repeat that one-liner because you need to remind them who the patient is before you tell them what you think of that patient, right? Before you tell them your assessment of that patient. So anyways, let's start the subjective. Subjective is the stuff you get from the patient, while objective is the stuff that you get from yourself, either through physical exam or through labs and imaging, right? So subjective is OPQRST. This is your history from the patient, right? What's OPQRST? It's the history of present illness, right? HPI. You're asking about the actual problem, the chest pain. After you get the history of the sickness, you now need to get the history of the person, right? What do we call that? Their past medical history. What conditions do they have in their life in general? You're learning about them as a person. At the same time as that, of course, you can get meds too, because you'll ask people, do you have any medical conditions? And they say, no. And then you say, do you take any medications? And they're like, yeah, I take blood pressure medicine, diabetes medicine, and thyroid medicine. So it's like they do have medical conditions, but they kind of like don't always know what you mean when you say that, because they think that they just don't see themselves as like sick, which is fine. So ask it together. Ask them about past medical history and then ask them what medications they're taking. If you're trying to be really thorough, you can, if it's like a full HPI, you can ask about allergies too, right? Because you want to know what medications they're allergic to. My whole point is that these are all kind of the same thing. Get it? what conditions you have, what meds do you take for those conditions, what meds are you allergic to. So this is all history of the person. First, you get the history of the sickness. Then you get the history of the person. Then, and I like to do stick figures to help me remember the three parts of the subjective after the HPI. So, okay, one person, right? Then you get the history of the family, right? That's like more people, right? So I put 2 stick men. Okay, that's just their family history. What conditions you have in your family, obviously. Dad has high blood pressure, mom had, diabetes, that sort of thing, cancer, all that sort of thing. Then the next level is even more people, the social history, right? You're not asking about the family, you're asking about the history of the society. That's what I tell myself to remember it. So I add 3 stick figures. Get it? So it's like the amount of people. One person's history, past medical history. The family's history, that's more people. And then the whole society's history, that's even more people. So there's 3 levels of how many people. That's how I remember the order of this stuff. So that's when you ask their social history. Family history is easy. It's just what conditions they have. Cancer, metabolic syndrome, etc. What does metabolic syndrome mean? It means 4 things. Obesity, high blood pressure, high blood sugar, high blood fat, right? It's all the blood problems that come from obesity and diet. They're the most common problems in America, right? Obesity, hypertension, diabetes, hyperlipidemia. Blood pressure, blood sugar, blood fat. Anyways, everybody has that. So that's why it's important. It's a good thing to keep in mind because, it's a good thing to ask about since it's most likely they have it. Anyways, what about social history? This is where you ask about drugs. TAR, that's how I write it in my little notebook, right? Have you ever used tobacco? Yeah, I smoked for 30 years. How many packs a day? About a pack a day. So that means 30 pack years. What about alcohol? Have a beer on the weekends. Okay, occasional. What about recreational drugs? What do you mean by that? Like cocaine, heroin, any other substances? No. Then I put it X. Okay? So that's how I do that. TAR, that's your substance history. What else is part of social history? Literally their social life. Who do you live with? And then they say my wife or my husband or my kids or my auntie or alone. What do you do for work, right? What's your job? Blah, 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 sedentary or dangerous or something. They'll tell you what kind of job they have. That's social history. Another part I'll do with that is sexual history. And this is where I'll, how many partners, are you sexually active? Yes or no? How many partners? 3. Do you use condoms? No. Okay. Then you tell them to use condoms because birth control cannot protect them from STDs. Only condoms can do that. So that's social history. With sexual, if I'm dealing with women's stuff, OB-GYN stuff, then that's when I'll also ask about menstrual history. Maybe OB history. Have you had kids? GYN history. Have you ever had abnormal pap smear, vaginal cancer, cervical cancer, stuff like that? But the main part of this that I always ask is the tobacco, alcohol, recreational drugs. These other parts are depending on the vibe and the context, you might want to ask about it. So family history is short. What conditions does your family have? Social history is short. Do you use drugs? They're pretty short, and then you could go longer if you want to. After you do these parts, right? First you do the main part, history of the sickness. Let's put a zero there because it's before. Then you do 1, the person, 2, the family, 3, the society. After you do those 3, then you have the review of systems, which is where you need to just ask a little bit of head-to-toe stuff. It's really helpful. You don't want to ask everything and waste all your time, but it's helpful because when you forget something that you should have asked, you can end up accidentally asking it just by running through your review systems, and you get info you need. So what do? I draw my stick man. He has a head, and he has a torso, which is pretty much your whole body, right? Your body is pretty much just a torso with a head and limbs added onto it. So what's a torso? It's the thorax and abdomen, right? Then add a head on top, add a limb on bottom, or if you want to be more thorough, add a pelvis and a limb on the bottom, right? So I kind of lied. The thorax is actually three parts. The torso is three parts. It's your thorax, your abdomen, and your pelvis, yellow for P. And then you add limbs. I put a little fire on top for inflammation or fever, right? The heat. And then I put a little, not lightning on bottom for like numbness and tingling. That just helps me. So that's my stick man, right? I draw the stick man every time on my notebook, and then I don't have to, it helps me to remember to go like, okay, have you had fever or chills lately? No. Have you had headache or dizziness? No. And then your eyes also have your head also has your eyes, right? And ears. So have you had changes to your hearing or vision? No. Okay. Nose. Any runny nose or cough? No. Okay. Or sore throat? No. Thorax is very important. What are the two organs in your chest? Obviously your heart and your lungs. So any chest pain or shortness of breath? No. Okay. Abdomen, any abdominal pain? No. Any problems with poop? So constipation, diarrhea? No. Okay. What about vomiting? No. Okay, good. Pelvis, any pain when you pee? No. Any blood in your pee? No. Right, those are the two things pretty much. Are you having to pee super often? Urinary frequency, right? No. Okay, good. I pee a lot, but I take a water pill, a diuretic. That's what they call diuretics. I take a water pill. The hydrochlorothiazide. Oh, okay, that's fine then. That you're peeing a lot. That's normal. Okay, what about leg, the limb? Any calf pain? Any swelling in your limbs? Any joint pain? No. Okay. Then I have the lightning bolt. Any numbness or tingling? The lightning bolt just stands for neuro. Any numbness or tingling in your limbs? No. Okay. Are you numb in your feet? Right? Diabetes. No. Okay, good. So that's my review of systems. And I kind of, in my notebook, I'll write these and put a circle by them, and like when I'm in there or whatever. And then if they say yes, I check it. If they say no, I exit. Review of systems. The review of systems is the end of your subjective, okay? So S, and when you get to the end, it ends with S, if that helps to remember it, okay? Good. So you have your three themes: the history of the person, the history of the family, the history of the society. One person, more people, most people. Before that, you got the history of the sickness, because that's what they're here for. That's where you start, obviously. And at the end, you have the history of just any other random symptom they might be having that they didn't mention with their sickness. So this is like very specific, the actual problem. And then at the end, you have just a whole run through head to toe just to like make sure you don't miss anything. And that's what I say to them. I'm just going to ask you some head to toe questions to make sure I'm not missing anything. Because otherwise they'll start reacting when you ask them random questions. Why are you asking about my chest? I'm not talking about my chest. It's like, it's okay. I'm just trying to be thorough. Just kidding. I'm not sarcastic with my patients. Anyways, okay, OPQRST, onset. When did this start? Tell me when it started, right? Because you come in and they say, my whatever is hurting. Tell me when this started. Was it all of a sudden, or was it like gradual? Okay. And does anything make it better? Smiley face, and then I write what they say. Yeah, Tylenol makes it better. Does anything make it worse? Yeah, when I move, it gets worse. Okay. Can you describe how the pain feels in words? That's what I asked them. In words. That usually makes sense to people without like putting words in their mouth. And then they'll say, yeah, it's sharp, or it's burning, or it's like a pressure, or whatever. And then for radiation, I wasn't saying. O is for onset, P is for provocation, so making it worse, or palliative, making it better. Q is for quality, like what is the quality of the pain, how does it feel? R is for radiating, but I also use it for location, because obviously it has to have a location that it radiates from. So they say, it hurts in my chest, and it spreads to my left side. Uh-oh, right? Then S is severity. I say if 10 is the worst pain you've ever had in your life and 0 is nothing, where would you put it? 6 out of 10. Okay, so it's pretty severe. I'm sorry to hear that. Yeah, it's pretty bad. And then T is times. It's not time, it's times. So I say, how many times has this happened? Or is this the first time this has happened? And they say, yeah, it's never happened before. So onset, provocation, quality, radiation, severity, and time. You always start with this list, and it's like you can get a good overview of what's going on without having to wonder, like, oh my gosh, like, what should I say? And then any other extra info you get, you can just put bullet points on your notebook off to the side. Next up is the objective. Now that we're finished talking to the patient in words, now we're going to get objective. Objective always starts with the vital signs. Why? Because they are vital. That means they're the most important, because they're going to tell you if the person is going to die or not. So you have the temperature, you have the heart and lungs, aka heart rate and respiratory rate, right? HR and RR. Then you have the heart and lungs again, because you have the blood pressure, which is relevant to the heart, and you have the O2 sat, which is relevant to the lungs. So you kind of, that's basically your vitals. Heart and lungs, heart and lungs. The only exception is the temperature, because you want to know if they have a fever or not. They're either febrile or afebrile. Okay, so those are your vitals. It's nice to memorize it so that you can jot it on your own notebook and everything. So that's how I memorize it. Heart or lungs, heart and lungs. Good. Okay. Which one is the juiciest one here? Not gonna lie, maybe this is wrong to say or whatever, grain of salt or whatever, but these ones kind of don't matter that frequently to me. It's like, this one is really juicy, do they have a fever or not? And then this one is really juicy because this is the one that's always like, actually, like, oh, their blood pressure is so high, 180, hypertensive urgency. Or it's like, oh, it's low, they're in shock. Or it's like, oh, it's like 140, they have hypertension, they need to take their medicine, or they need to get their medicine dose increased. Anyways, yeah, that's the vitals. You start with them. Why? Because they're vital. After you've done the most vital thing, which is vitals, you can now present the physical exam. For the physical exam, you use the same stickman, or I do, the same stickman from the review systems. But this time, it's, this time it's objective, right? This was the subjective stickman. Now we have objective. So, his heart and lungs are in the chest. He has his head. He has this little lightning bolt. He has a little fever thing. So for fever, what do I say? Obviously, I'm not like doing fever on physical exam most of the time, but I'll just say like general, right? General is they're well appearing and alert and oriented, right? That means they're acting normal. They're not like, acting like altered mental status. Then for the head, I don't normally do that either, but you could say like HEENT, head, ear, nose, and throat, or whatever. That you can say like, I see snot coming out. I don't know. I don't really do that often. Here are the main ones that I always do, okay? Cardio and pulm, right? The thorax and abdominal. Remember I told you your whole body is just a torso with some like head and limbs added on? So this torso of just these two things, thorax and abdomen, thorax and abdomen, thorax and abdomen, the two rectangles, that's the most important, okay? These are the parts that you always do on your physical exam for every patient by default. And then the other things, you pretty much would just do it based on the situation. So cardio, what do you say? Regular rate and rhythm with no extra heart sounds. That means no S3, no S4. Okay? For pulm, if it's normal, what do you say? Because you can't just say normal. You have to say it. You say clear to auscultation. Lungs are clear to auscultation on both sides with no wheezing or rhonchi. Because wheezing shows you a airway problem. Wheezing shows you a... what did I say? Rhonchi. Wheezing or crackles. Wheezing shows you an airway problem. Crackles show you a lung problem, right? So it's lungs versus bronchi. So that's why you mentioned those two. No wheezing or crackles. Those are the two different kind of sounds you could hear. Then abdominal, you say it's a soft abdomen with no tenderness to palpation, right? You press their belly on all four sides and in the middle and stuff, and there's no pain. No tenderness to palpation. But you don't only say the tenderness part, you also say if it felt hard or rigid. Why? Because if their abdomen feels rigid, that means that they have an acute abdomen. They need immediate surgery. They could be like bleeding inside their abdomen and stuff. So you call that rebound tenderness or guarding or whatever. But what you would say on physical exam is just that their abdomen feels rigid. Then for pelvis, that's if you're on OB-GYN, you do a pelvic exam, or maybe you want to do a digital rectal exam, or maybe you're doing a cervical check, right? Basically, that's stuff that you normally don't do on physical exam, right? Pelvis, those are sensitive exams for certain specific things. Then you have your, the legs. That's where I check for, this is another common one that I actually commonly do. Like on inpatient when they're in the hospital, I always check their, say MSK or a leg or something. I check for calf tenderness to palpation. So I push on the back of their calf and say, does that hurt? Because if it hurts, then that means they might have a DVT from laying in the hospital bed. So that's another generic one that you can do for everybody, because everybody in the hospital is at risk for DVT. And then neuro exam, you can move your finger in front of their eyes and have them follow it and say their oculomotor function is good, cranial nerve 3 is good. Or you can say like, whatever. You can test hearing and vision when you need to. Don't normally do that. But anyways, what I will say is that for general or for neuro, if you forgot to actually do a neuro exam and you're like, oh, like I want to kind of write more stuff so it doesn't seem like I just did nothing, then you can say like they're moving all extremities spontaneously, right? That's a little hack. It's not really a trick because it's true. It shows that like you paid attention to the fact that they can move their limbs, which means that they're not paralyzed, or they're not having like muscle weakness that prevents them from moving. So, okay, this is also where you would do like a strength, if you wanted to, a motor strength test of their upper and lower extremities. This is a thing I learned in PM&R rotation. When you have strength and it goes from like 0 out of 5 to 5 out of 5, what do those numbers actually mean? The 3, because it's in the middle, right? You have like, well, let me say 1 out of 5. The 3 is in the middle. So it's the one to memorize, basically. The 3 means that they can move their limbs against gravity. Okay? So that's like the special one to remember. So basically, if they can do more than that, like if they can move against gravity and against force, then you put 4. If they can move against gravity and force, and the force doesn't even like overwhelm them, then it's 5. If they can't even move against gravity, they're too weak to even do that, then you will put 2. So against gravity just means being able to lift their limb up by themselves. Anyways, that's a lot of talking. That's motor. Sensory, you can poke them and ask them, do they feel that? If they have diabetes, see on this leg thing, that's another thing that you can do for the leg thing. If you're an outpatient and they have diabetes, you want to do a diabetic foot exam. That's a big common one that you will do. So you'll take the little stick and you'll poke their feet on the different parts. There's a little picture that shows you how to do it on the stick. And say, close your eyes. Do you feel that? Yes, or whatever. So then you can do a diabetic foot exam and say it was normal, or if it was not normal, they don't feel it. So basically the leg is something that you always do as well. Outpatient, you would always do a foot exam on diabetics. And then inpatient, you would always do calf tenderness to see if they have a DVT. So as far as the physical exam that you actually do by default every time, it's these highlighted parts. Torso, abdomen, leg. Cardio, palm, abdominal, and then one of these 2 leg things, depending on if you're inpatient or outpatient. Okay? So again, the torso is the main thing. So that's the physical exam. All right? You did your vitals. You did your physical exam. What else is there to the objective? There's labs and imaging, right? So your objective has 2 parts. It has the part that you do kind of in the room with them, which is looking at the vitals on their TV screen, and doing your physical exam, right? Then there's the part that you don't do. There's a part that you kind of get from the computer before you even see the patient. And that's the labs and imaging. And the order is a certain order. Keep everything in this order. Because imaging is kind of more expensive and timely than labs. So we get labs first, and then we get imaging after if we need to. That's why it's in this order. What labs do you do? The main labs are the CBC and the BMP or CMP. So it's complete blood cell count and the basic metabolic panel. In other words, it's the blood cells versus the blood metabolites, right? These are the physical cells that actually make up the blood, and these are the little things that are floating around in the blood outside of that. In other words, this is going to be your red cell count, your white cell count, and your platelets. That's all it is. This one is going to be your electrolytes, which are extremely important. Okay, so these are the basic important things that you pretty much always get because you always want to know. Sodium, chloride, potassium, and base, bicarbonate or base. Which ones are even the most important here? These two. If this is super low or this is low or high, that's kind of basically an emergency. This is bad for the brain, this is bad for the heart. So you pretty much always get these. If you don't know what to do, just say, I want to get a CBC and a BMP. That's another little trick. Not really a trick though, but you know. It's like, I want to get a CBC and BMP. It's like they want you to know the reason you're getting it, but it's kind of like always correct to do that even if you don't know the reason. So when you don't know what to say, you can just buy time by saying that. I think I start out by getting CBC and BMP. Then they'll say like, yeah, good job, right? We want to know his electrolytes and everything because of his kidney issue. And it's like, oh, yeah. That's what I was thinking. Good. What other labs would you get? These are the default labs. And then after that, it's just like stuff that might be specifically useful to that person. If you do a complete metabolic panel instead of a basic, it will include like liver enzymes and stuff, I think. So I should know that. Anyways, I do know that. Right? Anyways, so yeah, you can say CMP and then it covers even more stuff. And the price is the same. I forgot to say that. So actually, you should never say BMP. You should just get the CMP because it's more information for the same price. So honestly, just do CBC, CMP. CBC, CMP. C and C. The two C's, those are the basic labs. Then for imaging. Okay, let's talk about imaging. 1, 2, 3, 4. Least invasive to most invasive, or least expensive to most expensive. Ultrasound, X-ray, CT, MRI. This one you almost never do because it's expensive. It's only if they have like a spine cancer or something, or soft tissue. If you really need to see soft tissue. Then you use CT for what? To see blood and bone, the B's. Or you'll use it to see tumors, right? I call it CT, cancer tumor. CT for cancer tumor. Okay. Chest x-ray, what's it good for? It's pretty much just good for looking at air and bone, right? So versus it's like bone and a liquid for CT, but it's bone and air for x-ray. See, x-ray is just good at looking at air. Not that impressive, right? So you look at their lungs and stuff, or you look to see if they have like, bubbles in their intestines or whatever. Yeah, and then ultrasound. What is ultrasound good for? It's good for looking at fluid, same as CT, right? Because your blood is a fluid. And it's good at looking at tumors as well. Just like the CT. Right? US tumors. CT, cancer tumor. So my point here is that X-ray and MRI I mean, yes, you use X-ray a lot or whatever, but I mean, especially for MBME and stuff, X-ray and MRI, I view them as the two lesser ones that I don't think about or use as much. And then ultrasound and CT, I think about as the ones that get used a lot. Like the default kind of imaging is actually a CT. Lay people know about X-rays more, but in actual like medicine, it's like the default thing is a CT. That's why people joke that they should put a CT scanner at the entrance to the emergency department because every single person, they just order a CT for them. Yeah, CT is probably the main character of imaging. Then the other main character is ultrasound. It's so safe. You can use it on babies and pregnant women. It's so like fast and quick and cheap. You can do it easy at the bedside. And it's good at looking at round objects, tumors, and it's good at looking at fluid. So it's just good. What I'll add to that for ultrasound is any cyst that has fluid in it, right? Cysts are like balls of fluid, so you'd use ultrasound. For any kind of stones, right? So watch this. For kidney stones, right? Not stones, rather it's stones, so it's a US, right? Kidney stones use ultrasound. Gallstones use ultrasounds. Yeah, you get the point. Stones, ultrasound. Yeah. And then appendicitis, you can use ultrasound. Appendicitis, or you can use CT. Appendicitis. It's so annoying, right? That's how I remember it from my shelf. Okay. Anyways, ultrasound and CT are the main characters, and then chest X-ray or MRI, just like whatever. Like, yeah, I'm gonna get an X-ray. What's it gonna show me? Mediastinal widening. Okay, whatever. It's not really showing me that much. Anything that has to do with blood vessels, vascular, then you get a CTA, CT angiography, because angiography means blood vessel picture. Anyways, I'm getting into the weeds. I just wanted to say imaging, the thing to think of first, so you're not like overthinking, not knowing what's going on. And then after imaging, what could you do? The next level would be a biopsy, right? Because these are all radiology. The only person who can know things, maybe tell you things more certain than the radiologist, would be the pathologist, right? But it's more invasive, so imaging is first. And then if labs and imaging didn't give you enough info, then you could even look at the biopsy or try to get a biopsy. But it's basically just these. So what's the objective? Vitals and physical exam, then labs and imaging, okay? 1, 2, 3, 4. For the assessment, you say your one-liner again. Mr. Naruto is a person with this history, and he's here for this, past and present. Then after you do your one-liner, you can now give your actual assessment. This is maybe the most important part. What does your assessment mean? It means your opinion, right? As a doctor in training, what is your opinion? Like Dr. Nelson says, that's what they're paying you for your actual expertise, your opinion. So you say, I always in my notebook, I do this before I go in the patient's room. And then after I leave the patient room, when I'm deciding on thinking about them, I'll either do this or this. So I make it a smiley face or a frowny face. Smiley means my overall impression is they're well appearing. They don't look like they're about to die or anything. They look like a normal person in a normal state. And the other part is their conditions, whatever conditions we were talking about, are improved since yesterday or improved since the last visit or whatever. Or I could say they're actually ill appearing. It looks like they're having trouble breathing and their face is turning pale and all of this stuff. Or I could say like, oh, it looks like their anemia or their whatever is worsening since the last time we saw them. Right? We would say, oh, their red blood count is lower than it was, or their white blood count is higher than it was yesterday. So that's not good. And then you say words like, yeah, their anemia is worsening, or their leukocytosis is worsening because of the white count. So you put words to make it sound doctory. That's what makes it an assessment. After you give your assessment of the patient overall, right, you give your overall opinion. After that, now you can talk about the actual problems. You can talk about your actual differential diagnosis, So you do that by problem. Let's say because especially in the hospital, they have multiple problems. So the first problem is chest pain. The second problem is he's also been having randomly his calf hurts when he walks or something, okay? And then he obviously has blood hypertension, and it's like out of control or whatever. You say the acute issues first. That's what they're here for. Then the chronic stuff that's not new, you could say it later, but I'm just gonna not say it now. So first, chest pain. What's your differential diagnosis, right? Because this is assessment. You do assessment before plan, diagnosis before treatment. So what's your differential? I think he most likely has ACS, acute coronary syndrome, so some unstable angina. Then you say why? Because his chest pain happens randomly when he's not doing anything, and it doesn't hurt when I press his chest, so I don't think it's a chest wall pain. I think it's his heart. Second differential, it could be a pulmonary embolism, a PE, because he says the pain is sharp. It's not only pressure-like or whatever. Third differential, it could be GERD, reflux, because he says it's also a burning pain that happens randomly, so maybe it's just reflux. The fourth differential, costochondritis, chest wall pain. Maybe it's just his ribs hurting, and that's why his chest hurts, and it's not actually his heart. Maybe it's an MSK problem. But most likely, it's not this, because when I pressed his chest, it wasn't tender. So it's at the bottom of my differential. So you say your differentials, 3 to 4 of them. Then for the calf, it's a different problem. So I'll say like, oh, I think number 1 differential, claudication from like his bad vessels. Number 2 differential, a DVT. He did say that he's a truck driver and he drives in the car a lot. Third differential, maybe MSK. Maybe it's just like MSK pain, overuse, or something, making a muscle sore. Okay, now we can go to the plan. What do you want to do for him? Well, in general, I want to get a CBC BMP, right? Like I said, always getting those basic labs. I want to keep trending his labs or whatever and keep monitoring or something. Those are like some... This is not... I don't just say it mindlessly, but these are like some generic phrases, at least if you're not really sure what to say. Like, yeah, keep trending, keep monitoring, you know. That's another little trick. So let's put that as well, an orange. Tricks in orange. Keep trending, keep monitoring, and see how he does. That's like a good filler phrase. That makes it seem like you kind of know what's going on here, and you're kind of thinking. It's like, yeah, I agree with that. Good job, med student. That's reasonable. Just keep trending. Kind of see how he does and everything. So that's a good like filler phrase. Just go-tos, you know, so that you have time to think. And then this is another go-to. I want to get a CBC, BMP, see what his blood's looking like. And then for the actual specific things, chest pain, it's like, okay, I'm thinking of, you do it by differential. So I'm thinking about heart problems, right? So that means I want to get an EKG, maybe an echo after, and I might order a stress test. That's kind of like the generic things that you say in a chest pain situation. Since I was worried about PE, I want to get a CT angiogram of the chest and look at his blood vessels in his lungs. In case it's reflux, I want him to try a PPI, like omeprazole, and see him back in a couple weeks. And if that helps, then we can think that it was probably reflux that was causing the chest pain. And then for the chest wall pain, I can ask him to try physical therapy or something. And then same thing here. It's like, okay, claudication, I want to get like a angiography or order an ankle brachial index to see like what the arteries in his legs look like. For DVT, I want to do a Doppler ultrasound, duplex ultrasound of his leg and see if there's a clot in there, right? That's what you do for DVT. And then for MSK, I'll just have him try physical therapy. So it's like your assessment is what you think is going on, and then your plan is what you're going to do about it. But you do it problem-based, because the patient doesn't just have one problem. So you assess the patient, and you have a plan for the patient, but then you also assess each problem, and you have a plan for each problem. So that's the word they like to use, problem-based. So that's super long, but that's it. That's the SOAP note presentation. You interview the patient in this kind of order with the S and the O. Then you think about your AMP. You tell the resident your AMP so that they can tell you if you're right or tell you what you're missing. And then what you present to the attending, all 4. One-liner, then SOAP. And then the attending is like, wow, good job, sounds good. Because the resident already told you the answers and stuff. That's how it goes. And they know that you do that. They expect you to do that, like to run it by the resident. So it's not seen as cheating or anything like that. So what are the pearls? Timing is important. Always think about timing. What's another pearl? Metabolic syndrome. Know what that is. Everybody has it. We already said it. Obesity, hypertension, diabetes, and hyperlipidemia. It's from diet and stuff. Trending things, timing. We already talked about that. Asking the resident. It's like the resident is like your person or your go-to or whatever. So you ask them stuff more than you ask the attending stuff. If you're working with residents, you ask them what their plan is. You ask them to critique your assessment and plan, and then they'll tell you what to fix. And then when you present to the attending, it's even better. Your assessment plan will be like, better. Yeah. Pearls, blah, 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 blah. Ask the resident. What else? Yeah, okay, that's it. That's fine. That's it for now. Another pearl is like you're allowed to check on your patient outside of when you're around on them. You're allowed to go back and check on them. And the things that you can do is relay a message for them or get them a cup of water or a snack from the little nutrition fridge for patients. You can do stuff like that. You can help with little procedures and things, etc., etc. Okay, that's enough.